Vicky? No one else? No one else outside? Okay. Okay, ladies and gentlemen, welcome to the college. On behalf of JRC PTB, I would like to welcome you to this launch event of the new internal medicine and Group 1 specialties. For those of you that don't know me, my name is David Marshall. I'm the Head of School for Scotland. I'm the Chair of the Heads of School UK. And I've been a member of the Curriculum Development Committee at JRC PTB since its inception in 2015. And I was a lead for the Implementation Committee. I'm an acute physician and I'm a rheumatologist, and I'm part retired and part still working. It's fantastic to finally host a live event here in the college building, seeing you face to face rather than appearing in these small boxes in my laptop screen, some of whom have very remarkable backdrops, it has to be said. For those of you who are attending virtually, I hope you enjoy the event, and I hope that we have no IT glitches this afternoon. From a housekeeping point of view, We are recording this event. There will be a refreshment break, and then there's drinks and canapes in the lawn afterwards, and we have no fire alarms planned. Today's event has been many years in evolution, and I use that word deliberately because we are not promoting a revolution here. October sees the 9th anniversary of the publication of Professor Sir David Greenaway's Shape of Training report, and that has provided the springboard for reviewing and improving medical training. That document provided us with the catalyst for the largest review of postgraduate medical education for almost 20 years. And it is that we're here to launch today. As we shall hear from today's speakers, the process of developing the internal medicine stage 1 training, which we know started in August of 2019, has been complex and it's been incredibly challenging. Most importantly, none of us expected to have a world's greatest public health catastrophe during that. We feel, however, that the IM Stage 1 process has proven to be very successful, and despite the massive pressures that the pandemic has put upon healthcare across the country. IM Stage 1 has proven by and large to be a very well-liked training programme by trainees and trainers alike, and it's particularly notable that the trainees now have greater exposure to critical care, to elderly care, to outpatient clinic experience, and most importantly to the acute unselected take. Furthermore, the assessment process is a much more holistic arrangement. Trainees are having a much more focused process in their assessment, utilising the capabilities and competencies in practice rather than the previous tick box assessment process. This year has in fact seen a fantastic uptake into IM Stage 1 across the United Kingdom with full recruitment, 100% recruitment into over 1,600 posts. That's the largest number of posts at that stage of training that we have ever had. This week, of course, sees the implementation of the Stage 2 curricula, and there have been huge challenges in getting to this point. We're absolutely delighted to welcome 3 new specialties into dual training, namely neurology, genitourinary medicine and palliative medicine. Today's event will detail how and why we have developed IM Stage 2 training, the key differences from the previous curricula, how internal medicine will be a more structured and integrated process, how educational supervision becomes even more key to the assessment process, and how the e-portfolio has developed to capture these new SIPs and GPCs that are required by our regulators. There will be a question and answer session with the panel that will conclude today. So if you have questions, please keep them towards the end and we will take those questions then. There are many people that we need to acknowledge in the development of the new medical training structures, and I would particularly wish to welcome or to thank Professor David Black, who's here today, who established the Internal Medicine Committee in 2015 at JRCPTB. This then evolved into the Curriculum Development Committee in 2018, and these committees have been expertly chaired by Dr. Alistair Miller, who unfortunately cannot be here today as he's walking across Greenland. We'll hear later in the day from Dr. Mike Jones, who's the Federation Medical Director for Training and Development. Unfortunately, Mike can't be here for medical reasons, but will be presenting through the Teams process. He has provided dynamic and thoughtful leadership and has been hugely important in us arriving at where we are today. From 2015, Professor Andrew Elder led the assessment subgroup and Dr. John Firth led the curriculum subgroup, and I'd like to acknowledge their huge contributions to that process. I'd also like to give particular thanks to Dr. Phil Bright, the HEE Clinical Advisor for IMT, for all his leadership in implementing the curricula, not only in HEE in England, but also across the 4 statutory education boards. From the very start of this review of training, we've involved trainees, we've involved employers, our regulators, the GMC, the British Medical Association, and lay representation. And I'd like to thank all of them for their contribution to this complex process. Heads of school have also bought into this redesign of curricula and have provided superb intellectual rigour and critique throughout. I'd particularly like to give thanks to the members of the SACs who have invested a lot of time and resources in developing their individual curricula and the supporting documents. The chairs and the curriculum leads within the SACs should have particular thanks. And I'd also like to thank the college education teams for delivering training throughout a number of roadshows in the earlier part of the IM Stage 1 implementation and a process of this rolling out for Stage 2. Finally, no committee ever delivers the goods without a dedicated management and administrative team. And I'd like to give very special thanks to the hard work and dedication of our ladies at the back, Zoe and Vicky. You've been wonderful colleagues and friends throughout. So now to our first speaker, and he really needs no introduction to a medical or indeed a lay audience. He's graced our television screens for the last couple of years on a very regular basis at the COVID updates, and it's our honour to have a recorded video presentation today from Professor Sir Chris Whitty, the Chief Medical Advisor and the Chief Medical Officer for England, who will outline the importance of specialists having generalist skills. Thank you.
Over the next years. Much of medicine is enduring, but the relationship to specialisation and the relationship between generalist skills and specialist skills has shifted throughout all of medical history and will continue to do so. And I've just illustrated this with some of the people along that pathway. And if you just think just within the period that the NHS itself has existed, the NHS looks completely different in terms of structure to what it did at the point of its initiation, including a much smaller bed base, a much larger number of doctors and nurses. It had a very different group of diseases that we're dealing with. So the reasons for the shift are partly to do with traditions and partly to do with external factors. Now, I want to be really clear that this is in no way a negative commentary about specialisation. Specialisation within medicine has improved clinical outcomes really quite remarkably for individual conditions. And just two of many possible examples, the impact on cardiovascular disease, so the astonishing improvement on coronary heart disease mortality, and also the improvements in treatment outcomes for multiple cancers shown on the left. So specialisation has a very important role and will continue to do so. And this, along with improvements in science and improvements in living standards, have led to a very steady increase in life expectancy over the last 150 years. There's been a slight drop-off more recently for a number of reasons, including COVID in the last 2 years. But the trend of this has led to a very different age structure over time, which is a very welcome development. But what this does mean is that looking over the next decades, comparing medicine where it was roughly the point I qualified in medicine over the last 10 years and looking forward 10 years, you can see that there is a very substantial shift in terms of the population getting older, which is something widely understood, but also that age distribution being highly concentrated in certain parts of the country, particularly the peripheral areas, rural areas, and coastal areas. As major conurbations, much less of a change. But we're going to see a really big shift in the demographic pattern. Now, the reason this is relevant to generalism is really through multimorbidity. As you grow older, as we all grow older, we accumulate longer-term chronic conditions. They'll be made up of clusters of diseases, so they're not necessarily random assortments. There'll be clusters, some of them around well-known risk factors such as smoking or diabetes. Some of them will be, for reasons we don't yet understand, that there is a clustering. But there are going to be groups of conditions, and this happens at an earlier age in those living in areas of deprivation. But the result of that is if you have someone who has problems which are predictably occurring in the same person, but they are quite unrelated in terms of the body system involved. Let us say the eye problems and the cardiovascular problems of diabetes. If you have people who are only able to manage one of these, that leads to less good outcomes. Most people with any chronic condition have multiple conditions, and there are lots of ways of cutting these data, but everyone who looks at this comes up with the same answer by slightly different routes. So this trend towards multiple chronic conditions is going to continue. It's also important to say that this isn't just a matter of aging, and partly actually due to the ability to keep people alive at earlier ages. Younger adults are also, many younger adults also have multiple conditions, and there are particular times of life, for example, around pregnancy, which can put stresses on the system, which increase the impact of this. So you've got lots of situations, not just in the very oldest. Now, what we've therefore had is a period of increasing medical specialization where people have more and more lost their generalist skills, and at the same time an increase in multiple morbidity or multiple chronic conditions. And these are really pushing in opposite directions. And the reason that this doesn't really work is because delivery of care and medical science are currently optimized for single diseases. Clinics tend to be single disease focused. Medical training tends to think up a disease from basics to clinical and applied. National guidelines, NICE, for example, guidelines tend to be about single diseases. Laboratory research is very often single disease focused, and very often, in fact, clinical research is, with people with multiple morbidities actively excluded. So the result of that is the system is quite the reverse of being optimized for the future, which is of people having multiple conditions. The importance of generalist skills has been exemplified by the COVID-19 pandemic. And when we look at the absolutely remarkable response of medical and other healthcare professionals from many disciplines working on a completely new multi-organ disease, what you've seen is the ability of doctors to flex towards areas which they're not used to. When we came to people with severe COVID, typically they tended to be either very elderly people with therefore likely multimorbidity, or people with multiple chronic conditions, for example, ones associated with obesity. COVID also demonstrated the power of multidisciplinary clinical research. That's, in a sense, a slightly orthogonal issue that's still an important one. So I think if you look at this trend towards multimorbidity, I think we really need to respond to that. And that means ensuring that clinicians from almost all specialities maintain and celebrate generalist skills, because these will be critical in responding to the rise in multimorbidity. This doesn't mean there's a tension between specialists and generalists. It's not an argument for recreating the role of the general physician outside some very peripheral areas where it's really important, but rather it's allowing specialists to maintain their generalist skills rather than systematically to drop them, which has been the tendency increasingly over the last 20 years. It is completely wrong, I think, for us as a profession, as physicians, to expect this all to be done by GPs, geriatricians, and in the acute medical setting. I think we should see this as a responsibility for the whole of the profession of physicians across many different disciplines. So this is really an argument for maintaining generalist skills whilst continuing to specialise. Thank you very much.
I'm sure he heard that. I think it's nice to put the context of why we have been doing what we're doing, and I think that was very eloquent from Professor Sir Chris Whitty. We move on now to my immediate boss at JRCPTB, Mike Jones, and as I said earlier, can't be here today, and he gives his apologies for that. But Mike's going to give us a talk now on the development of the curricula. Mike is the Medical Director of Training and Development at the Federation, and he's a consultant in acute internal medicine in County Durham and Darlington Hospital. I'm sure many of you know Mike. Over to you, Mike.
Thank you, David. could I get first slide, please? Okay, that's interesting. I can see myself on the screen and not a great deal. However, just wanted to comment on Chris Whitty's presentation. He sent his apologies that he couldn't be here. Given that he has so many important roles, he doesn't deny his role as being a real clinician, and he's on clinical duty today and felt that he was unable to join us because of that. However, the things to come, this illustrates the slide for an Alexander Korda production. And whilst I'm not suggesting that the 100 years that is mentioned in the top right-hand corner of that slide is important, it is clear to see that there are far more people involved in the presentation and development of the things to come when it comes to these curricula. David's already alluded to many of the people, and I will add my own thanks later on. But I think we have to accept and recognise that this is something that has been a long time in its gestation and has involved an enormous number of people. I can only see half the slides. Is there any possibility that I can get the whole slides? Fit to frame, okay. Right, thank you very much. Okay, next slide, please. I'm here to provide a little bit of background as to why the curricula were to be modified. Modernising medical careers, which culminated in the disaster that was MTAS, the Medical Training Advisory Service, application service rather, has come into significant disrepute over the years, and indeed at the time of MTAS was a highly political hot potato, which led to Patricia Hewitt having to eat humble pie in the Commons. However, from that, core medical training had been developed to come into being to provide a structured training for physicians in the early part of their physician training. It developed a syllabus with a spiral curriculum so that trainees were to get a learning opportunity and then revisit learning opportunities as they maintained and developed their competencies. It was said that this curriculum was competency-based, but I think it's fair to say that in the 2 years that was allowed for core medical training, it often wasn't the case that trainees were allowed to progress because they had become competent, and certainly the number of people who moved through core medical training in less than 2 years was very small. However, it also introduced the concept of workplace-based assessment so that trainees could be assessed, but also use those as part of the evidence that could be accumulated in their portfolio so that when they were being reviewed, that they would be able to show that they have experienced appropriate learning opportunities. And in association with that, there was the generation of educational and clinical supervisors, and indeed, in association with that, some of the more forward-looking deans at the time, including David Black, formed faculty groups so that trainees could properly be assessed by a group of their seniors and those that had been properly trained to supervise. Next slide, please. As things progressed, the Orange Guide, which had been trying to provide guidance of how trainees should move through their training program, and each year had their review of in-training assessment. The Orange Guide became gold, and so along with other changes, RETAs became ARCPs, which we know today as the assessment of competence progression, the annual assessment or annual review of competence progression. Next slide. Next slide, please. But there were drivers for change. Shape of training has already been introduced as a concept by David and Professor David Greenaway, brought out 5 main themes in his report from October 2013. Firstly, patient needs should have been considered to drive how we must train doctors in the future. And there was an emphasis that Sir Chris has already mentioned about changing the balance between specialists and generalists. We had to have a broader approach to postgraduate training because whilst it was recognised there was a tension between service and training, we needed to make sure that there was more flexibility, and I'll come back to why flexibility was an increasing concern, but we had to have more flexibility in training. Next slide. So, shape of training certainly shaped thinking as regards the generation of new curricula. But in addition to that, the Future Hospital Commission, which was generated by the Royal Colleges of Physicians, among its 11 principles of care, emphasised that there was a need to enable people to improve quality. It was a very early mention that quality should be included within training. The Francis report, which of course looked at the North Staffordshire Hospital and highlighted many areas where there was less than perfect patient care, but it also emphasised that people had not felt able to speak up about the problems that were occurring. And Francis himself emphasised that there should be an area where training included the ability to speak up. And this helped lead to some of the changes that GMC introduced, including the framework of generic professional capabilities, which had to be embedded in all curricula by 2020, but also the standards for medical education and training, including curriculum design, which became effective from January 2016. So there were lots of formal drivers for change, but also there were informal drivers. Next slide. A paper developed by the present president of the Royal College of Physicians had shown that there was increasing trainer and trainee dissatisfaction. Some of this dissatisfaction was based around the burden of assessment. So people were feeling that in addition to the formal assessments that they had to undertake, there was also an increasing burden associated with the workplace-based assessments. The tick box mentality that's already been mentioned had led to people being signed off, sometimes inappropriately, but sometimes without due consideration about whether they were truly competent in a specific skill. But also the tick box mentality and the atomized competencies were not conducive to people taking their training in an appropriate fashion. At the same time, it was clear that the medical registrar job was possibly the most unpopular medical job in the hospital. And in particular, there seemed to be little formal training to enable people to take up that role, which of course is a very important role in terms of the overall function of the average acute hospital. Taking into consideration the patients that we serve, of course, again, has been said, generally there is increasing age. The complexity of illness is also increasing. And if I had time, I could show you the inexorable increase in numbers of the medical emergency admissions that are taking place. And indeed, anybody who's working clinically at the moment is well aware of the pressures that the NHS is under associated with medical emergency admissions. And when we look at the flexibility of workforce provision, emphasis was being put on the geographical disparity between certain areas and others, and therefore the learning opportunities that were available. There were significant concerns about role changes, not about the changes being taken up by others, such as specialist nurses, but that this was influence what training was required. But at the same time, when we looked at the workforce requirements, new procedures and treatments were sometimes supplanting the more established, and the obvious one of those is the cardiac physicians taking on more and more intervention percutaneously, which led to a diminution in the need for cardiac surgeons. And at the same time, there's been a change in the demography of trainees. 50% female probably remains a fairly conservative estimate, but there is no doubt there is an increasing feminization of the workforce, which has its own set of implications, some positive, some less so, but certainly we have to recognize how the individuals are wanting to train and the flexibility associated with that. Next slide. So, what was the process of change that was undertaken for the physicians to respond to these drivers? As has already been alluded to, David Black, as medical director for the Physicians Training Board, working on behalf of the Federation, led the generation of new committees and the ability to generate the curricula. Again, names have already been mentioned of John Firth and Andrew Elder in taking lead roles. John with the curriculum and syllabus subcommittee, Andrew Elder with the assessment subcommittee. I think it's fair to say that David was a little self-effacing in his introduction, because without implementation, we wouldn't actually be here today. So I think along with John and Andrew, we have to acknowledge the very significant role that was taken by these three individuals. But as also been mentioned, as these groups worked through, the Curriculum Development Committee took over function and was led by Alistair Miller. For all of the internal medicine curricula, there was a huge consultation exercise, and it's not a mistake. Trainees is a bit like location. It is the important part of the consultation, not to minimize the others, but of course, if we are trying to change training, it is the trainees who have to go through this. But there is an absolute debt needing to be paid to the SAC chairs and curriculum leads, the heads of school, the Core Medicine Training Advisory Committee, and those from the NHS employers, deans, GMC that played in. And indeed, there were 6 development days to try and get the internal medicine curriculum to a point where it could be recognised as being an appropriate curriculum for stage 1. And a proof of concept study confirmed that. Next slide. So the headline changes for the internal medicine stage 1 curriculum was it was for 3 years indicatively instead of the core medical training, which was for 2 years. The capabilities in practice, or SIPs, were going to be far more holistic assessments to replace the multiple atomized competencies with a simplified syllabus, although the need to learn medicine has not been taken away. Medicine in its breadth is extremely extensive, and we do expect people to be able to manage across that breadth. But we were looking at how we would entrust trainees at different levels of supervision, so that by the time they come to CCT in internal medicine, and indeed in their specialty, they will be at level 4, i.e. capable of independent practice. For internal medicine, there was, in the stage 1, there were specific experiences mandated, including a specified number of clinics, experience in critical care, and experienced in geriatric medicine, the latter recognising our increasingly aged population. But it was also clear that we would have to have a stage 2 for internal medicine training, so that when trainees entered specialty training in the group 1 specialties, the internal medicine component was inextricably bound to specialty training. And we were looking for more specialties to do internal medicine so that we would increase the availability of those that could undertake the medical registrar role and complete their training in the generalist aspect of internal medicine. Next slide. One of the constraints, however, was that training could not be lengthened. This was a very strict mandate, an absolute requirement. And therefore, if internal medicine training was to be increased, higher specialty training would be decreased. And hence there became a requirement for Group 1 and Group 2 specialties. Group 1 specialties were those, or are those, that will train with internal medicine, and Group 2 specialties are those that will train within the specialty alone. Next slide. So the changes in duration, however, are illustrated here. Core medical training prior to 2019 consisted of 2 years, followed by 5 years of higher specialty training, indicative in most of our Group 1 specialties. And at that stage, there was 24 to 48 months spent in general medicine. As we start on the new curricula, IMT lasts for an indicative 3 years, and higher specialty training is now 4 years, but the indicative element of internal medicine is now 12 months, as opposed to the indicative 24 to 48 that occurred prior to 2019 and the introduction of internal medicine training. Next slide. And these are the Group 1 specialties, and I acknowledge again the contribution of the chairs and the curricular lead. On the left-hand side of the Group 1 specialties, and in yellow are the new Group 1 specialties, and it should be emphasised that neurology will now be training in stroke medicine as well as in internal medicine, whereas genitourinary medicine and palliative medicine now take on internal medicine, in addition to the more, if we like to say, the traditional Group 1 specialties, which are shown there. Next slide. I said that I was going to indicate those that have taken an incredibly significant lead role in developing this, and these names are shown here. Zoe and Vicky are acknowledged here, but I will make special mention of Zoe on the basis that, having got us to the implementation of the Group 1 curricula, she's moving on and moving away from PTB, and her contribution has been invaluable. The other person that I think needs a specific mention is Lynn Katz, on the basis that, as David says, the admin and support mechanisms associated within PTB are very, very critical. And without Lynn, I think both David Black and myself would have found significant difficulties in contributing significantly towards the generation of the new curricula. Next slide. I've put this slide in on the basis that this is a good illustration of whether your glass is half full or half empty. If your glass is half empty, we're heading into storms and we've got clouds ahead that we're going to have to navigate our way through. When it comes to the new curricula, I would prefer to view it as that's going to be a beautiful sunset, but it will also indicate nice days ahead as we try and ensure that the training we provide does indeed suit the patient population that we support. Thank you very much for your attention.
Thank you very much, Mike. As I've mentioned, we'll take questions at the question and answer session. Many of us in the room today will be old enough to remember MMC, and it's interesting how time moves on. If you Google MMC now, it comes up as Mickey Mouse Club. So things move on in training. So we move on to our next speaker. We're just 5 minutes behind schedule at the moment, but we have two speakers next. We have Dr. Sue Pound, who is the curriculum lead for the Geriatric Medicine SAC. Sue, again, will be known to many in the audience. She's the Vice President of the Royal College of Physicians in Edinburgh and works as a geriatrician in Fife. And we have Rebecca Winter, who is a geriatric medicine trainee, recently returned from a period out of programme in research, doing her PhD, and Rebecca works in Brighton. So Sue and Rebecca.
Thank you, David. This was here.
Yeah.
Yeah.
Hello.
Good afternoon, everybody. David's kindly introduced us. Rebecca and I thought we would try and do something a little bit more interactive, and Rebecca does also need to leave before the panel session. So if you do have any questions, we are actually happy to answer them if they're within our 30-minute time scale. Just picking up on the last slide from Mike, we are glass half full people, aren't we, Rebecca? And as the curriculum lead for geriatric medicine, I have to say I've been incredibly lucky in having fantastic support and interaction from my trainee colleagues. So, Rebecca, do you want to just say a little bit more about yourself in this sort of process of developing the curriculum?
Yeah, so I think Sue and I are from almost opposite ends of the UK, but we came together very romantically over an SAC board talking about the geriatric curriculum. So I was a BGS, British Geriatric Society trainee rep, and was then involved in the SAC of going through the curriculum. And I guess like what I wanted to emphasize was actually how much trainees were involved. So certainly in geriatric medicine, for example, there was myself and a number of other people that then this spanned over 4 years, so there were different representatives offering different opinions, and all of that was fed back even to a local level. So I do think that within each specialty there has been a lot of trainee involvement. I would really echo that.
And I think we all recognise that change is always challenging, isn't it? And change sometimes makes us apprehensive. But I think both of us intrinsically believe that the new curriculum is a better curriculum, and it's a better way of assessment. So we hope we will be able to allay some fears and persuade you of that for the rest of today.
Can I just say as well that if people do have anything like while we're going along, we deliberately put less slides. We have a lot more we could say on the matter. So if there are any questions as you go along, please do ask.
We initially had the question why in our brief today, but I think the previous speakers have clearly elucidated the reasons why the curriculum should change. There are generic changes, as we've heard, to all curricula. And as Mike has mentioned, there are a smaller number of higher level learning outcomes. Now, I'm hoping that everybody here and online has at least looked at their own curriculum and the internal medicine curriculum, so that you will be aware what we're talking about when we're talking about capabilities in practice, because I haven't gone through each of those in this presentation today, but we will expand a little bit more on those. But one of the key things that has changed is that they have replaced that very long tick box of the previous curriculum on the e-portfolio. We're moving more towards holistic assessment of how trainees are doing. So rather than focusing on specific tick boxes, it's much more aligned to how are things going in the workplace. Do you feel able to lead that acute medical take? Are you able to run an outpatient clinic? Rather than, can you tell me exactly what all the 40,000 causes of falls in a frail older person are? Can you put that into practice? It does mean that as educational supervisors and trainers, we are more and more asked for our judgment about entrustment levels for our trainees that we are working with. And I think as we will bring out, and subsequent speakers will also bring out, that link between the educational supervisor and the trainee is becoming ever more important. And that is something that both as trainees and trainers, we really are going to have to invest some time in. We will show a little bit how the progression of competencies, capabilities and entrustment levels will develop throughout training. Now, the internal medicine grid that we will show perhaps doesn't have as clear progression, and that you start at quite a high level. You've only got 12 months left in IM stage 2, but for our specialty curricula, in the ARCP decision aids, you will see a much more obvious progression between where you start in ST4 to where you complete training, be that in ST7 or 8.
Well, I just say for that, that if people do want to look at that and they're not familiar where it is, if you look at your own specialty or the IMS2 decision aids, which you can just search via Google, you can see them at the bottom. There's a table with numbers from 2 to 4 in them for each part.
Now, Becky and I are both geriatricians, so we haven't focused on geriatric medicine. And when we spoke with Mike and Zoe earlier, we were asked to bring out a little bit about the generic professional capabilities in particular, because I think people are a little concerned about how we might evidence those. And hopefully Becky and I are going to chat about some ways in which we might be able to do that. So although some things have changed, there are quite a lot of things that haven't changed. Mike mentioned we haven't thrown up all of the syllabus for physicianly training in all of our specialties. Most of the syllabi are actually very, very similar to what we've already been using before, and certainly that is the case in geriatric medicine. The underlying syllabus, what you need to know about geriatric medicine, has changed very little. It's more about the way that we assess good practice. So what has not changed is good supervisory practice, that good link between educational supervisors and trainees. Mike mentioned the ARCP process. That too hasn't changed. There will still be an annual review of progression in training. And we also haven't changed our use of supervised learning events and workplace-based assessments as a means for providing at least some of the evidence that will still be helpful in assessing your capability level. So Becky's just going to draw out one or two of the differences between the previous curriculum and the one that we'll be moving to later this week.
Yeah, so I think I'm a very visual person. I think like it can be a bit overwhelming to kind of picture what it might look like. But the things that are the same are that there was the GIM special decision aids. Now we have the IMS2 as well as your speciality decision aids. So there are still 2 decision aids that trainees will need to look at, but they are different in their expectations within them than it were previously. Previously on people's curriculum, they might have to click for a GIM one as well as their own specialty, whereas now it all sits within one online curriculum, and I'll show you what that looks like in a minute. There are still the same kind of assessments that you are familiar with, as we said, although the numbers are different from the previous decision aids. As we've talked about, the timings changes, so in the new curriculum people will start at ST4. The main difference is about the capabilities in practice and entrustment levels. Does everyone here feel happy with what they are, or shall I? Yeah, everyone feels comfortable with those. So I think that, you know, even if you're a glass half empty kind of person, surely no one can feel sad about the fact that you have to wait for an hour for your portfolio to load down all the things that you've linked, and then you lose your place on the page. Like, hopefully that will be a thing of the past. So we've got the overall capabilities in practice, as we said, thinking about someone holistically. So the capabilities in practice are more of an overarching statement. So can manage an acute take, can manage a patients and unselect patients in outpatient clinic, for example. They're much more of a broad understanding of a patient person, and then the entrustment levels are different to how the rating used to be. So the capabilities in practice, or the SIPs, are grouped into 3 categories. So there's the generic, which are linked to the good medical practice and GPC frameworks. And these talk about ethical things, legal things, research, patient safety. There are the internal medicine clinical ones, and they cover clinical tasks which are essentially internal medicine, acute take, for example, and including things like palliative care within them. And then there are the specialty ones. And how this looks is that there are 6 generic SIPs. There are 8 clinical SIPs, and in terms of your specialty, there are different numbers, but in geriatric medicine, for example, there's 7, and some of you will have the additional theme for service SIPs within your specialty as well that you need to do. So this is what it will look like in your curriculum. I think the most common question I would get asked by trainees is, will everything get pulled over? And the answer is no, but that you will still have access to your old curriculum, and what people will need to do at the beginning is will need to, with their gap analysis and in their first educational supervisor meetings, will need to, bring forward some of the overriding themes of what people have in these areas. So when you'll be able to click on your portfolio, you can see that you'll be able to click down and see the different SIPs that you have for each thing, and the practical procedures will come up separately.
So we've talked about this concept of capabilities in practice, and to help us, guide us, I think, towards what sort of experience and evidence that the trainees need, we've broken these capabilities down further into 3 different areas. First of all, there are descriptors which indicate the level of knowledge, the skills and the attitudes which need to be demonstrated for each of these capabilities. Secondly, there are links to those GPC framework domain links. And thirdly, there are some suggestions as to what sort of evidence you might collect to be able to help you and your educational supervisor agree the level that you're working at. The other thing that has changed is that we are asking trainees to self-assess, if you like. So when you're speaking with your educational supervisor, it's really important that trainees have thought to themselves, well, what level of entrustment do I think I'm working at? And then you can get the same opinion from your supervisor and work out whether you're close together or not. And I think that's a slight difference. You've done it with the MSF before.
There was ranking, I think, on some people's portfolio, but it fit slightly differently, and you had to show where you prove where you met it on the previous portfolio.
So from the point of view of evidence, because I think we've had quite a lot of questions about evidence and what might include, there are no long lists of tick boxes, thank goodness. We're both very pleased about that, but most of the evidence that you might collect is very similar from the evidence that we're using at the moment. So SLEs such as mini CACSs and case-based discussions, ADOPTs, workplace-based assessments, they will all stay the same. ACATs, all of those are the same that you're familiar with. Many curricula have suggested courses. Now, increasingly, the GMC are asking us not to mandate things unless they are absolutely necessary and cannot be provided in any other way. But it may still be that, for example, teaching skills are still best obtained or evidenced by going on the trainer's course, so not a specific course, but a course that will give you those skills. But it doesn't have to be that course. It could be other evidence, but it might be easier to collect it in that way. Becky's already mentioned that your evidence will all still be there. Curricula have changed before, and the evidence never disappears. So the evidence will always be there, but if you can help signpost that for your educational supervisor and for those on the panel at the ARCP, that will be very helpful too. And I think one of the key messages is that regular meetings with the educational supervisor is going to be really important in this process. One of the really big changes for us, perhaps as educational supervisors and trainers, is that the assessment is going to take the form of asking at what level trainees are working. Now, we have done this to some extent in our previous educational supervisors report, but this is a little bit more standardised. And there are going to be 2 types of global assessments. One is for the generic professional capabilities, the generic SIPs, and one is for the clinical SIPs, both the internal medicine SIPs and the specialty SIPs. So for the generic SIPs, you're going to be asked to assess trainees on these global anchor statements. So is the trainee meeting expectations for their level of training? Or are they struggling a wee bit and below that, and we need to identify areas that extra experience and skills are required in? Or are they performing above what might be deemed to be expectations for the year of training? So those are for the generic SIPs. For the clinical SIPs, this is about entrustment levels. So what can you trust your trainee, your colleague, we talk about trainees, but it's really the same for all of our colleagues, whether they're nurse practitioner colleagues or AHP colleagues. At what levels are they able to provide clinical decision making? Level 1 is not really mentioned in any of our curricula. That's really a clinical sort of observer type position. But levels 2 to 4 are embedded in all of the ARC-P decision aids. So level 2 is where a trainee will often start moving into ST4 at a specialty level. So they need quite a lot of supervision from senior colleagues, be that a consultant clinical supervisor or more experienced registrars, or indeed other members of professionals, allied health professions who might have more experience in that level. By level 3, trainees are doing what they're doing probably with the acute medical take when they start, which is that they can pretty much get on with it, but they need us to be around and to be available to answer questions on a pretty easy access and rapid basis. And the key one here is going to be level 4, an entrustment to act unsupervised. That means that you are ready to fly as a consultant. So once you are given a level 4 for any SIP, that means you are ready to become a consultant in that particular capability. So at the end of training, by the time of CCT, you should be level 4 or independent in all of the capabilities in your own specialty curriculum. And this is just an example from the internal medicine ARCP decision aid, but a very similar grid will be present in each of the curricula. As you can see, for internal medicine, trainees have already done a lot of training. They've had a lot of experience in IM through the 3 years of internal medicine. So they're entering ST4 being able to do most things with little hands-on supervision, but needing a wee bit more direct supervision, managing acute care within the other specialties. But as you can see, by the end of ST7, ready to fly, independent in all of the capabilities. You may find that for the specialty curricula, such as ours in geriatric medicine, at ST4, you've got a lot more level 2s where you will need to provide more support and supervision to trainees just entering a new specialty. We were asked by Mike and Zoe perhaps to concentrate in this next section a little bit on the generic capabilities and how trainees might provide some evidence to their supervisors that they were meeting these generic capabilities. So Becky has drawn out 2 of the generic SIPs, and we're going to have just a wee bit of thought about how you might evidence these in your portfolio.
Yes. Just before we come into this, I think like when I hear our talk, when I hear about the signposting, because I think we're going to talk a lot about signposting within this part, signposting maybe makes people feel a bit apprehensive about actually how much work that might involve or what kind of thought process that has to involve, particularly at the beginning. If some people might feel like they have to summarize their whole curriculum. I think like it's about an overview of the levels that you're at in the SIPs, and actually that should be able to come with your self-rank rating alongside like with a line or 2 about why you think you're at that level, actually with not as much time as I think some people are fearing. But we are going to talk about signposting quite a lot even within this. So the first SIP though we're going to talk about is about being able to deal with ethical and legal issues related to clinical practice. Now the descriptors, I mean I don't need to read them out, but they include about your legal responsibilities, ethical requirements, saying sorry to patients, and ability to lead the clinical team in an open manner when things go wrong. And with regards to the descriptors, then each thing links to the GPC domains and also evidence. If you remember one thing from our talk, for me, I'd really like it to be that you don't have to have all these things to be approved for it. Equally, so you don't have to, on the slide before this, you don't have to have every single one of those descriptors within it. It's an overall holistic view, and there's some ideas about how the person might have it. So I think I've been on call this weekend. I was just going to talk about a patient that I saw that came in with a fall, and that they, when I listened to their chest, I could see that they had a grade 3 sacral sore. And so I would like to do a CBD on that patient when I'm back at work. And I was thinking that when I do that, that would be a good kind of case that then I could say, I would really like us to do a CBD on that patient to talk about some of the clinical things, but also I wondered if also we could focus on some of the ethical and legal things that I did and that we could signpost within that. Because for me then, I think that I would be able to show you how I recognised it, how I knew to raise a safeguarding, how I knew to communicate that with other members of the MDT, and how I took some of the juniors with me to see and then talk about it. And I think that that's probably the best way to evidence some of these is often within a clinical case.
I think that's really important, and I think that demonstrates, Becky, why the GMC feel that these generic competencies are really important for the provision of good medical practice. Yeah. And for us as supervisors, I think we just need to think a little bit more holistically when we're completing those SLEs. So as you say, rather than just commenting on your clinical management of the patient, if we can try and remember which of the generic capabilities have also been demonstrated by your holistic management, and remember to focus on those as part of the SLE, which can then be used by you to link to pieces of evidence for that capability.
Yeah, so I guess it's like about what I've taken away from my understanding is to be a little bit more explicit about how you have met some of the more generic SIPs within some of your more clinical scenarios.
I think that's right, and perhaps as a supervisor it reminds me that I'm relatively good, I think, about commenting on communication skills as a more generic issue, but there are a lot more generic things like ethics and teaching and training and use of guidelines that we can also comment on in SLEs as well.
Yes, and of course there are non-clinical things as well, such as your M&M meetings referring to the coroner, complaint, things like that can also have their own one if required, but I do think they fit nicely with the clinical ones. And then so the other one was about carrying out research and managing data appropriately. Now there are lots of descriptors. As I say, you don't have to have all of these things. They're examples about how someone might be in a holistic manner. And they include things like research, about critical appraisal, about following guidelines, and about putting guidelines into practice. And you can see that, again, it shows you the GPC domains and how they link, and there's a lot of overlapping domains within the generic SIPs, and also about the evidence. The evidence quite similar, and of course, we all have to do our QIPs or audits within it. I think, again, with research, there are some easier ways, aren't there, to kind of link it. So if you do your good clinical practice course, you can talk about that. With your audits, you can talk about that. But again, also with cases, like I had a patient yesterday who came in with spontaneous bruising, and he is a paramedic and very well read, and he came with lots of resources from NICE guidelines about why he's taking his ticagrelor for longer. And although it maybe wasn't my favourite time on call on a Sunday, it was good to be able to then go through some of that with him, and I guess that would be something maybe not as niche as that, but there are lots of times where you would talk to patients about the numbers or the reasons why you're making decisions, and just being a little bit more explicit about that. Also, I can think of times where I've been taught about asthma guidelines on training days, for example, and then putting them into practice and writing about that, how you might put it into practice.
I think that's right, and I think there are many ways that you can demonstrate these capabilities. Some of them might be going to a course, but others are very much more how you integrate guidelines, I think, into clinical practice. Again, quality improvement, yes, you do need to do 2 quality improvement projects, one for our specialty and one for internal medicine. So there are ways of developing those quality improvement capabilities through formal training, through informal training, and through actual practice as well. So I hope we have persuaded you very quickly that assessment of capabilities in practice involves looking across a range of different skills and behaviours. Clinical supervisors, so we are aware that for many deaneries and for many specialties, the educational supervisor may not be working directly with the trainee, and therefore the educational supervisor's link to the clinical supervisors is going to be key, both through tools such as the multiple consultant report. The Rough Guide, which is a really helpful resource, talks about faculties, so getting local groups of consultants together to feed back a much more broad view of any particular trainee's progress, particularly if you don't know that trainee well, is also going to be really key, I think, in helping the educational supervisor come to an entrustment decision, because we do need to remember, as I think will be described in detail later on, there's educational supervisor's responsibility to indicate the level of entrustment for the ARCP. Talk very briefly about the Rough Guides. This is a really good resource. Every specialty has one. Do read that if you haven't already, because it will help you in that transition to the new curriculum. I would just like to say thank you to my specialist society, the British Geriatric Society, who've been really proactive in doing some webinars and developing resources, and thanks to Becky and the trainees for inputting into that. I suspect other specialist societies have similar resources to you, so look out there on the JRCPTB website, but also on your specialty society websites as well, because there's lots of information and resources out there.
So the frequently asked question live document that we have on the British Geriatric Society website doesn't just include geriatric medicine. There's questions that are updated regularly, and they're about a range of questions that I'm sure lots of other people ask, like about the linking of evidence, about acceleration, about who doesn't have to transition, who does, etc., all on there as well.
Thank you.
Thank you very much, Sue and Becky. I would pick up on one point that you made, which I think was so important, about the trainees need to look at the decision aids both for specialty and for GIM, because I think there has been a little bit of a narrow focus on specialty at the exclusion of internal medicine, and lip service maybe in the old curricula was paid to internal medicine training, whereas now it's imperative, it's embedded, it's so important. So 2 educational supervisors' reports and 2 decision aids to look at. We will hear more about this. So thank you very much indeed. Thank you. To conclude this session before we break for refreshments, I'm delighted to introduce Colin Doig, who's the chair of the General Internal Medicine SAC, having taken over from John Firth. Colin is a consultant cardiologist in the Northumbria Healthcare NHS, and he's a director of clinical support, I believe. Is that right? Was, but has now decided to step away from that. And Colin is going to speak to us about the requirements in the internal medicine rather than the specialty side. Thanks, Colin.
Yes, I'm also medical director with responsibility for professional standards, so it feeds in very well to a new curriculum and a new form of assessment. Thank you very much for the opportunity to come and speak today. And as has already been paid tribute, I have to say thank you very much to John Firth, in whose footprints I now follow. He was a colossus and did a huge amount of work in what we are seeing today, and I just want to say thank you very much on a public basis to what he has done, both for the curriculum but also for general medicine over the course of the last 5 or 6 years. Any change is always a threatening time, and we all approach it with a degree of anxiety. It is probably appropriate that as we come to, if I can move this forward, right, as we come to the end of the first tranche of IMY3 trainees, that we are now looking at what to do with the higher specialty trainees in this new revamped curriculum that we are all facing. And I'm aware that there are at least 2 audiences to which we are speaking today. There are trainees who are going to be affected by these changes to a variable degree, depending on where they are within their existing training programme, but also to clinical and educational supervisors who are a completely different faculty, but also need to hear this message because their input to this process is more than vital. It is absolutely of paramount importance. So I want to almost start by concluding And these are the take-home messages. And I would, as has already been emphasised, this is more of an evolution than a revolution. And there is an awful lot that is the same and familiar that we will be using going forward that we are asking trainees and supervisors to use at the moment. Undoubtedly, it is more holistic. That does not mean this is simpler, this is an easier process for all involved, but it will allow a far more rounded approach to be seen and a far more pragmatic approach to trainees. Those of you who sit on ARCP panels will be very familiar with the importance of ES reports coming through to the panels and informing the panel of trainees who are doing exceptionally well, but also those who perhaps require some additional assistance. And we have got better and better at it as educational supervisors over the course of the last few years, and we need to continue to build on that going forward. As Becky has already indicated, we're able to use the evidence that is already there in the portfolio, so it's not as if you're starting from scratch from day one. And the conversations I have had both locally in the northern region but also at national level with the new Group 1 specialties, I'm very impressed at the extent to which they are ready and are prepared for what is a complete revolution for them. I think we cannot underestimate the importance of the change that they are now facing. And very, very broadly, they have accepted that challenge and have run with it in a way which potentially could become a template for other disciplines going forward. Time will tell us whether or not that is an appropriate view to take. We're going to be using the same SLEs and workplace-based assessments as before, plus the OPCAT, which I will come to towards the end of the talk. But I would like to remind everybody that general medicine is not what many people think is general medicine, which is the acute unselected medical take. General medicine undoubtedly is the acute unselected medical take, plus it is how you perform in outpatients. It is how you handle yourself on the ward. It is how you interact with nursing staff and pharmacy and other healthcare professionals. And one lesson I've learned as a long-standing training program director for general medicine is that specialties have often had a much, much better handle on how their trainees are performing in these softer skills than general medicine has, which is one of the reasons why we have moved our ARCP week in the north to after most of the specialty ARCPs have taken place, because we're then able to use their assessments, their tools, their softer intel to inform us more holistically about the trainees' progress. And all of that, therefore, is entirely consistent with what is planned through this new curriculum and its assessment. I've already indicated how important the ES report can be. The ARCP process will be paramount. About half of the regions in the country will continue to do completely separate GIM and specialty ARCPs, and the other half will do a mixed ARCP process. It doesn't really matter which approach is used as long as the IM ARCP process is robust in those particular regions. The aim or shape of training, which as we've seen is 9-10 years old now, is to allow folk to CCT capable of independent practice as we are now putting it in both a specialty and in internal medicine because of the needs of the population that we are serving. The expectation is that anyone, as they CCT, will be capable of independent practice in any sized hospital. Therefore, that means that we might not be dependent upon specialty input or specialty takes. And of course, it does allow the springboard for post-CCT development and other credentialing. Also, unashamedly within the shape of training was the recognition that the medical registrar position was unpopular, to put it kindly, untenable, perhaps to put it more realistically, and that we did need to increase the amount of work and attention to this band of trainees, and we needed to support the acute medical take with an adequate number of medical registrars. And for that reason, a number of additional disciplines who did not traditionally input into general medical take were going to be brought on stream. The aim of it all is to give even the most specialist of us, and I say this as a cardiologist, the most specialist of us, general skills. I have long regarded myself and been proud of the fact that I'm a general cardiologist, but I've also recognised that for many, many years I am in effect a geriatrician looking after patients coming in with primarily cardiac problems, and I ignore the other problems at my patient's peril. Changes to the curricula. These have been outlined, and I will go through some of them with reference to general medicine in a minute. The capabilities in practice, the SIPs are being introduced, and I think most trainees and probably educational supervisors will recognise this as a major advance from the top 21 presentations and the other presentations that we have previously had to acknowledge and to reference. It does allow educational supervisors and clinical supervisors to provide a much more accurate and holistic assessment without necessarily having every single box in the curriculum shaded and coloured in. It allows you to make notice of where individuals are working well, where you are very comfortable that they are performing to a high level, taking into account what they themselves have made of their own performance. And we have to bounce this back to trainees that they are professionals and they have a professional expectation of themselves. They know better actually than most of us about how well they are performing. We need to give them room to express that. The entrustment levels you have heard about, and the progression grid, which I think takes us a long way away from the virtual years, particularly with regards to general medicine that we had under the last decision aid, which led to a degree of confusion at best. Others might say it's complete chaos at worst, based on whether you were at the end of year 1, year 2, or year 3, and these were virtual years rather than calendar years. So I think the progression grid is a major advance. What is unchanged will be the ARCP process, the absolute necessity for good educational supervision and workplace-based assessments, SLEs, in the way that we have been using them over the last decade and a half. As has been described already, SIPs describe professional tasks or work within the scope of the practitioner as defined by the curriculum. And there are a variety of activities to which entrustment levels, competency, can be applied. And they are a way of, if you like, defining a global assessment where you as an education supervisor will be comfortable saying, I'm happy that this trainee is working well, and you as a trainee will be happy to say, yes, I provided sufficient evidence to satisfy me, my educational supervisor, and any external reviewer that I am performing at the level that I claim that I am performing at. And as you saw in one of the last slides in the previous talk, level 4 for all SIPs will need to be demonstrated by the time someone CCTs in GIM. For the vast majority of trainees, that will not be a problem and should be something that we should be looking forward to achieving without too much in the way of revolution. The capabilities in practice, we've seen 6 generic, 8 in internal medicine and a variety for specialty. The internal medicine ones are defined here. So these are the 8 internal medicine clinical CIPs, and they cover the acute unselected medical take, behaviour at outpatients, acute care in other disciplines, ongoing care at ward level, end-of-life care, multidisciplinary team meetings, and resuscitation and recognising the deteriorating patient. Now, all of these are already in the framework that we are using up until later on this week, but they're much more easily accessed in this format, and they link far more directly to the GMC, good medical practice, etc. So here's an example, I've got 2 to share with you, of the management of an acute unselected medical take. And it is exactly what you would want your registrar to be able to do. I remember being taught when I was training to be a PACES examiner that the acid test of someone who was going to be a medical registrar and to pass the PACES was, if you were going to be phoned by this individual at 3 o'clock in the morning, would they give you sufficient information that you'd be able to work with them to come to an appropriate management plan for that patient? I found that a very useful threshold, not least to assess the registrars with whom I work on a day-to-day basis. So it's all about how do they take the history, how do they interact with the patient, how do they deal with the family, are they able to come up with the appropriate diagnosis or differential diagnosis, how do they use the investigations that they have determined were going to be appropriate for this individual, and how do they then manage the patient, how do they convey that both to the patient, to the family, to the team, etc. So the sort of things we all do as good doctors is just defined there. And all we're asking is that you demonstrate that as a trainee and you identify that and acknowledge that as an educational supervisor. It is very easily mapped to the General Professional Capability Framework. And these at the bottom of this slide are the sort of workplace-based assessments or SLEs that can be used to demonstrate it. So, plus la chance, c'est la même chose is very evident, I think, here. For CIP4, this is the outpatient activity. These are the various criteria that are going to be looked at, and they basically cover very, very similar information and will allow individuals to work within an outpatient setting, both within their own specialty, but also in other disciplines, to allow people to demonstrate that they are actually able to manage at outpatient level and that from day one in their consultant job, they can run an outpatient clinic and support registrars or other junior doctors working alongside them. All of this feeds in to effectively an assessment process. So the learners do the work, they provide the evidence, they sit down with the educational supervisor, they rate their own performance, and the ES rates their performance, and hopefully they get somewhere fairly close, or at least somewhere where they can work from that particular point. The assessors make accountable judgments, and the professional judgments then allow them to make holistic decisions and entrustments with regards to progression and what work needs to be identified going forward for further development. As in the previous curriculum, there are a number of specific numbers that do need to be achieved. Now, the numbers, whilst they are absolute numbers, are really there as an indicative level that folk have actually seen enough cases that it is reasonable for an outside assessor to determine that those individuals have actually had sufficient experience. So the new numbers that we will be looking at for IMS2 will be 750 patients on the acute medical take over the whole of the 4 years, 5 years if you're in certain disciplines, of IMS2, of whom 100 will need to be in the final year of training. As all of you in this room and most of you online will be aware, it is a requirement for trainees to perform a minimum of 3 months, or the equivalent of 3 months of general medicine, broadly taken to be acute medical take, but I referenced my earlier comments, in the final 12 months of training. We recognise that we need to be doing the equivalent of 3 months acute unselected take, or 4 weeks of full immersion in acute medicine in the final year. Different models will apply for different regions, in different trusts and in different areas, so we can't be absolutely prescriptive about it. Over the 4 years, 5 years for some disciplines, 12 months of continuing care for patients admitted with acute medical problems. There will be the requirement to do 20 clinics in specialties not linked to your core activity or to your, they call it the parent specialty. I think that's old language because it's no longer the parent specialty. They are, we now have 2 parents. We're co-parenting with GIM and specialty, but 20 clinics other than your identified other specialty. And that will vary from place to place and largely, I think, be driven by individuals' needs and by individuals' assessments. And we will undoubtedly have a debate about which are going to be acceptable and which are not going to be acceptable. I'll tell you what is not acceptable, and that will be those individuals who are going along to something like ambulatory care where there is no consultant support and it in its essence is a DVT clinic. That would not be recognised. But if you're going and performing an acute medical assessment programme, or you're taking part in an ESTEC facility, for example, which is fully supported by consultants and you've got a wide panoply of medical patients coming up, that would be an entirely appropriate clinic. There is a requirement for an educational supervisor for internal medicine. That actually is not a revolution. That is already there in the existing curriculum. We haven't perhaps been as strict about ensuring that that is the case in the past, but going forward, that will be an absolute requirement. So educational supervisors and trainees are warned. That, for me, is probably the biggest change of the whole lot, that will become far more important and far more rigorously policed than had been the case before. GRC-PTB have indicated that all timings are indicative. They always have to be indicative. And for those who, you'll see that throughout the training programme, apart from when individuals are in specialty year, 1 acute unselected take per month is recommended. Many disciplines are going to be effectively putting them together and giving you 2 weeks of general medicine or unselected medical take in a block. There will be a variety of different options around the country, and we will need to see which ones best suit the curriculum over time. And that's why I think we do need to see this as an evolution rather than a revolution. Educational supervisor, we are going to ask that there is a separate ES for internal medicine. Now, this might be the same individual as the educational supervisor for specialty, particularly if they have the ability to supervise internal medicine themselves, or if they've got very close links within the hospital environment to allow them to be very familiar with how individuals are performing on acute unselected medical take and the other aspects of general internal medicine. But in most places, or in many places, this will be a separate individual, and that will be a bit of a challenge, not least for those of us who are running ARCP panels, to police this and to run this, particularly over the first 2 or 3 years, whilst the whole concept gets bedded in. I suspect it will give postgraduate education centres and directors of medical education something to think about how these individuals are allocated. One word, or a few words on the outpatient care assessment tool. Many of trainees have for a number of years used an ACAT as a way of assessing or demonstrating that they have been attending clinic, and use some of that clinical material as evidence against various competencies within the GIM framework and curriculum. The ACAT was not designed for that purpose. The OPCAT has been designed for that purpose, and I recommend it to you, and it's going to be of particular use for this IM Clinical SIP 4, which I highlighted earlier. So I conclude, really, as I started, that this is an opportunity for trainees and trainers to adopt a far more holistic approach. Hopefully, it will make the whole process of demonstrating one's competence to all far simpler, far more straightforward. You still require evidence, but it should be much more logical and much simpler to achieve. Most of the Group 1 specialties are well prepared. You're using the same material as we've been using for a decade and a half, and a reminder that GIM is not just the acute medical take. Thank you.
Colin, thank you so much. That was a beautifully eloquent run-through of a very complex area, so thank you very much for that. I'm going to finish with a brief anecdote, which was kind of alluded to by Colin in his speech. The new Group 1 specialties, I think, have embraced the new curricula particularly well, and I really, really thank any of you in the audience who are involved in the 3 new specialties. The anecdote goes back 5 years when I was asked by a neurologist in Glasgow, the head of the medical school, in fact, John Paul Leach, to speak to the ivory tower that was the Institute of Neurological Sciences in Glasgow about what we were planning. And there was abject horror on the faces of the neurologists. And the meeting finished with John Paul bumping on the table and saying, how many amongst you are better doctors for not being physicians? And I thought that absolutely hit the nail on the head. And since that point, they have completely moved forward. They've embraced the idea of blocks of training as they're doing. And I think we really are in a new age when we are seeing what was traditionally a specialty, an ivory tower specialty with no internal medicine, now embracing dual accreditation and dual training. So I think we are at a really interesting and pivotal time. So I'm not have any more anecdotes. You're all desperate for your cups of tea and some refreshment. We break now, and I think we are reconvening in 15 minutes. Thank you very much. Super, thanks very much. So thanks for coming back in time. I'm not even going to try and pronounce Raghu's name because I've just known him as Raghu over the years. And many of you will know Raghu. Raghu MBE, it should be said. I only found this out today when I was looking through and realised that Raghu was given an MBE for services to COVID in the summer of last year. So congratulations on that, a bit belated. Raghu is head of school in Severn, but about to demit as head of school, is very well recognised within college, having been the Lineker Fellow, having been on council for a number of years, and is going to speak to us today, along with Megan, on how the training year runs. I think this is a kind of practical session. It's akin to Sue and Becky's session, a kind of chat through how the training year runs. Megan is the co-chair of the Royal College Trainees Committee. She's currently out doing a PhD. She's working in the West Midlands and is a rheumatology trainee. Obviously chosen an excellent specialty, I think. So without further ado, I'll leave the floor to you.
Thank you, David. Thanks for the very kind introduction. This has been a journey of love for a long time for those of us who started this back in 2015, and it's lovely that we've got here. This is going to be very interactive between me and Megan, between Megan and I, as my old English professor used to say. So Megan, do you want to tell us a little bit about yourself? And what we'll do is we'll go through a very practical view of how this is going to land. Off you go.
Thank you. So as the introduction states, I'm currently a trainee. I am most of the way through my training. So actually quite a lot of the issues that we're going to discuss today are pertinent to me. So I'll be asking lots of questions about things like transition and what it means to be somebody who's going to have to move on to this new curriculum, and also what it means for some of the new trainees coming in. So as Raghu has said, we're going to go for a very sort of practical, on-the-ground sort of take on what this is going to be like. So I'm going to start with the first and possibly most important question. So we've heard a lot about how important the trainee educational supervisor relationship is going to be with the new curricula. So how should I, as a trainee, approach that initial educational supervisor meeting? And do you have any suggestions on the format of how that meeting should be?
Here's one I prepared earlier. I'm going to look at this from three viewpoints. The audience of the trainee who's coming in, the audience of the educational supervisor who suddenly, instead of having to tick all those boxes, and yes, Becky, I do remember those going up and down at 37 ticks. But there's a wider audience here. There is our regulators, there's the RP panels, there is the public out there. So I take Colin's point, we start at the end and work backwards. So when you get the CCT and we get the stage 4s, work backwards to the year when the RP panel is going to sit and how we're going to meet that requirement to get past that hurdle every year. And then roll it back to the most important meeting, which is the initial conversation between the educational supervisor and the trainee. This is crucial because that's where you're going to start this journey of how are we going to meet what the curriculum requires us to do. And I hear what Colin said about how the DMEs might have a think about who the education supervisors are going to be. There is a lot of evidence out there. The rough guide's helpful, the RP decision aids, the curriculum, there's a huge amount of work we put into it. But on the practical ground, when you're sitting down with the education supervisor, what we want to do is, what do I want to get out of this year? What are the SIPs that Sue so eloquently pointed out? How are we going to meet that in this requirement? Are there any exams we need to take? And if so, how are we going to help us through it? So that's the first bit of it.
Yeah.
the second and more important bit, I think, is identifying where and how we can get the various resources. Some of it might be within your trust, some of it might be regional, and some of it might be national. But behind all this, it's absolutely key to have some smart objectives as to where you're going to go. And behind that is how we're going to use the various assessment tools. And I love the concept of what Becky had put in about using a case and saying, can I link that? Can I link that? But working that on the hoof can be difficult, especially in a busy take. You come to Gloucestershire, the take is so mad that you don't have the time to think this through. But have an idea where we go. So I've done a lot of talking. That's the danger with me, so I will shut up and I'll let you.
But that was really helpful. So I think that gives trainees an idea of what to think about prior to the supervisor meeting. And both then the trainee, the supervisor can go in with a shared plan, have the discussion, document everything. I think the other thing that will play on people's minds is this idea that we now need an educational supervisor both for the subspeciality and for internal medicine. And I, for instance, as a rheumatology trainee, some of our consultants work within internal medicine, but some of them don't. So, and previously, for instance, I've been perhaps in the minority that I've had an educational supervisor within endocrinology. So I have at times had two to make sure I've covered that. And it sounds to me like that's going to become much more common with the introduction of the new curricula. So do you have any ideas on how this dual supervision and perhaps some remote supervision should work?
Okay. In all fairness, we've always needed an educational supervisor for the IM curriculum, or GIM as was. It was a rule more honoured in its breach than its observance, if the truth be told. So where there isn't an educational supervisor who's able to manage that, and I think Colin touched this in his topic, you do need to have a clinical supervisor who's able to look and oversee that. And that's a two-way conversation, because there is the named clinical supervisor who's going to be responsible for the sign-offs and looking at how the curriculum works. But actually, every clinical supervisor, in its broader sense, is going to help this conversation grow. And again, we talked about clinics. We talked about what general medicine is. And the management, that holistic patient that Chris Whitty challenged us to do. I think this is where the conversation with the local faculty group, who can meet on a regular basis to decide what the educational opportunities are for the individual, but more importantly, where you have a trainee who is struggling, who has a problem, we need to be absolutely clear that we're able to support them even if the educational supervisor is not there with them all the time. And that's where I think we, as a group of clinicians, need to work together. And yes, I am speaking to the wider clinical supervisor group out there to try and help and identify early where there are issues that we can support our trainees to get over the bar.
Brilliant. And I think probably linked into that, because it speaks to the wider faculty group again, but now that we have these very entwined curricula, then how do we get the balance right between the subspecialty and the internal medicine, and how can perhaps that wider faculty help with that?
Thank you. This is the vexed question that has been vexing us for a very, very long time. And I like David's comment about neurology, and it's not just neurology, it's all of us trying to make the time to get the education and training to map the entirety of the curriculum. And yes, it's a challenge. Yes, as a head of school, I had 23 program directors telling me how they possibly could not meet their curricular requirements because they're all doing the take or getting days off. I get that. I am a practicing clinician, yes, I get it. But ultimately, we owe it to our trainees to be able to get the requirements of the curriculum. And the balance, because these are indicative numbers, what we want to do is to see whether the trainees are able to meet that requirement. How can we guide them through it? And if they need more time, they need more time. If they need less time, they need less time. It's not a fixed process. What we want to do is to get the balance right in the two separate RPs. And I like the idea of having the general medical RP after the specialty RP done, because you can then start looking at the holistic picture of the training. And you know, no one size will fit all. And as a craft specialty, we do get the challenges of finding the time. But time and experience has to be found if we want to get to the end point. And that's why I started where I started, is see yourself at the end and work backwards. Periodic meeting with the educational supervisors and the trainees is crucial. And that is why I think, again, as Colin said, it's important that the directors of medical education have a conversation with their educational supervisors to make the time for conversations to happen between trainee and trainer. And where there are problems, to identify them and early, so that as head of school, I want to know where there are problems and see if we can help them.
Great. And on the theme of time, then when we were brainstorming, I suppose the difficulties on the ground of implementing new curricula and trying to learn lessons from the implementation of IMT, there were sometimes local problems with gaining experience away from parent specialities because of all of the pressure on everybody's time. Do you have any suggestions for how to deal with these?
So let's focus on the wider general medicine. And it's not about getting enough take. It's not just about, I will do 20 clinics in pulmonary hypertension and that should be fine for my GIM, for respiratory medicine. It's about understanding how you manage the patient. It is about how you understand how the rest of the patient works. And I'm going to be careful what I say next, but I, as some of you know, was a censor of the RCP, and when I went for that interview, I was asked what general medicine was, and my slightly tongue-in-cheek answer was general medicine was a bit of the patient that was attached to the right coronary artery. Apologies to any cardiologists in the room. But that, to me, is the critical bit here, is understanding how the specialty or the subspecialty you're working in and training in interacts with the rest of the patient so that you give the patient the best possible care, because we don't have the workforce as it is, so we have to be able to manage that. And yes, time is critical. It is difficult, but we have to find a way through this.
Okay. So, moving from one difficult topic to another.
Thanks.
So how about for trainees transitioning to the new curricula? So for example, someone who is a GUM trainee will newly be joining the Group 1 specialities and will be taking on GIM. What differs for that group?
Okay, let's take the new Group 1 specialties first, and then I'll talk about the transition to the old Group 1. As David alluded, we have been doing a huge amount of work at deanery level to make sure that the new GIM Group 1 specialties are able to fit in, and there's been a number of conversations about attachments, about placements in different forms, sometimes as immersive training, sometimes as conjoined training, depending on where they are. And it's more challenging in some places. Palliative care, for instance, of course, they're out in the hospices as well. But I think because we've had such a long lead time, certainly I can talk about the 7 where we've had enormous conversations with a number of providers and the hospitals, and I'm confident that we have a plan for each individual trainee to go through the system. Of course, we learn from rheumatology, because in rheumatology, at least in the 7 for a long time, used to be a single specialty, and they had moved to GIM, and our rheumatology TPD was extraordinarily helpful as a resource to tell the new GIM TPDs, no, it's okay, this can be done. And yes, it takes a lot of time. There is a lot of anxiety about finding the post, but we always find the posts. Trusts are always willing to find, even if we don't have numbered posts, we find a way to get the attachments to do it, because it's a curricular requirement. It has to be done, and we find a way through this. It's getting the trainees through, it's getting the trainers through, and finding the posts and the money to go with it. And that's what we've been doing as a deanery. And there's a lot of work that's gone into it, and touch wood, it should go through. The second bit of the transition is almost the bigger one, which is what's happening with the existing trainees who were in the old curriculum, so to speak. And the regulator is very clear that the transition, the trainees have to be as far as is feasible in the latest possible curriculum for the benefit of the patients. But there are some exceptions to it, and this is very clear if you're in your final year of training, and there are a number of other exceptions as pointed out there. But again, I think the last date was July the 18th, wasn't it, where they had to declare this. But again, a conversation between the educational supervisor, the program directors, and if need be, the head of the school, to interact with the trainees and then make a recommendation to the dean is the way forward here. It's not going to be easy, but actually, as Sue pointed out, the evidence is there. And I go back to this initial meeting. When you have the initial meeting with the educational supervisors, bring this along and say, hi, this is what we've done. These are the evidence that we've got. And then we can transition to and make reference to in the educational supervisor's report, in the curriculum, because Colin will attest to this, and many of you have sat in the RPs will attest to it. The more evidence that is there on the portfolio in an easily seeable place, it becomes easier for the panel to get the correct outcome. But it's not about the RP. It's not about the outcome. It's ultimately a conversation between the trainee who wants to say that, yes, I can meet this curricular requirement, and here's how I can show you I can do it, and for the trainer to be confident enough to sign and say, yes, you do. And that's because we don't have all those boxes, thank heavens. But it's actually harder, much harder for the educational supervisor to sign these off. And it's much harder for the trainee to demonstrate that if you turn up at the last minute with all these things to be signed off. It's so much easier if you did it through the period in that weekly, monthly conversations you're going to have. And my recommendation to all trainees and trainers is get those dates in the diary now, because events, dear boy, something will happen, so get that in, have the conversations, and if there's any problem, escalate it. And the routes of escalation, just to remind, not that you don't know, is within the local education providers will be through the directors of medical education and through the deaneries for the entities formerly known as deaneries, through to the program directors, heads of school, and the associate deans, because they're all there to help. And that, I think, is the key here.
And where does the gap analysis come into all this?
Okay. So with the gap analysis, the way I look at gap analysis is not so much looking backwards as looking forwards. what is it that the trainee can bring from what they've done, and the university has been doing this with APLs for a long time, bring that discussion in from the various evidence that they've got. And sometimes some of that evidence may already be in the portfolio, some of that might be an experience but not been evidenced, and you bring that in and have some kind of workplace-based assessments to bring it in. And then what we can do, particularly during this period of transition, is to look at how we can make the gap work, minding the gap there, because there is no need to redo everything. And this is a capability-based curriculum, so if we can demonstrate that the capability is met, then we can use that evidence that is there with perhaps a few more as needed workplace-based assessments, the local faculty group reports, to then rate against the latest SIPs. And that makes the job of the ARCP panel easier. It makes the life of the trainee in the last few seconds before the ARCP goes in easier. And ultimately, it makes the journey that much more smooth. Because it's tough as it is. Let's not make it harder.
A little bit of preparation goes a long way, I think, for this.
Absolutely.
Okay, so final question for you before I let you sort of summarize the important points. And I think we've had some ideas on this already, but I'm just interested to pick your brains. So how do we best capture internal medicine experience that we gain, for instance, in clinics or on the wards, that it is interspersed with everything that we do? How do we best capture that and record it for the portfolio and for the supervisor?
Okay. Often, particularly in an unselected take or a weekend ward run, as Becky was talking about, it's an opportunistic learning that you gather. The advantage of having the portfolio is that could be captured through reflections or workplace-based assessments. ACATs are good for that. For the clinics, of course, you've got OPCATs. You can get those in, but almost have a mental idea of where these could fit into. And it's easy enough to do for the clinical SIPs, but don't forget the generic SIPs are just waiting, and there's so much of the generic SIPs that can be mapped with the right workplace-based assessments in. And yes, everybody is busy. And I know throughout May and June, my in-tray was full of many trainees saying, oh, can I send you an ACAT? Can I send you this? And the more you do, for the education supervisors supervising the room, the more you do, you're going to get more. So that's the rules. That's fine. You do it. But it's that conversation you have with the trainee. It could be brief at the time and could be followed up by a more detailed conversation later to make the workplace-based assessment, to then link. And this is where the original discussions happen. And when you then meet up next for your monthly or weekly or fortnightly meeting with your education supervisors, take this along and align them and get those into the portfolio. The more evidence that is there, the easier it is as a panel. And I can't reinforce this, because there is nothing harder for an ARCP panel to have to sift through various bits of the portfolio to try and gather that evidence, particularly these days when the trainees are not there. And therefore, it's just a plea. And I know I'm talking very much from a head of school point of view, but it just makes everybody's life easier if things are clearly signposted.
Brilliant.
Right. Breathe.
You have sorted it. You have sorted it. We can all go home now. That's it. That was really, really interesting. And can I just ask, did you discuss your questions and answers beforehand? Because it seemed very spontaneous, I have to say.
Young Megan was in.
So I had an impromptu bit of annual leave, which meant that this has been genuinely very spontaneous.
It seems extremely spontaneous. So.
We had brainstormed some important things to discuss,
Brilliant.
And then the rest of it all came from Raghu's mind.
Look, I think you've covered it beautifully. I think a round of applause. I was going to make a comment on your discussion, and I think it's a really integral point to this, and that it was alluded to in Colin's talk that we may see the new curriculum resulting in a way of change of how we integrate medicine and specialty training. And the new Group 1 specialties have embarked on this by saying we want blocks of time. We want 3-month or 6-month blocks where a trainee will step out of their neurology programme, do 6 months of medicine and then step back to specialty. And I wonder if your thoughts, Raghu, are that that might happen for the traditional Group 1 specialties when they look at what's happening in the new specialties and saying, we want a piece of that.
Yeah, I think there will be a lot of learning. We'll all learn from each other. We'll learn from between specialties, within specialties, and I'm hastily making notes from everybody else's ideas. So adapt and adopt is what I believe in. I think these kind of meetings are helpful for us to share experiences, and whatever works, we'll take it unashamedly, because ultimately a period of transition, of change. I was a pre-Kalman trainee, so I remember when Kalman came along and how challenging that was. I went for my very first Rita and everybody didn't know what to do back in the mid-90s. So every change is challenging, so let's make it easy for everybody and let's support each other. That's what we're here for.
Pragmatism, I like that, I like that. Thank you both.
You.
We're going to move on to the final talk today, which is from Rifa Begum, and Rifa is the ePortfolio and CPD lead for the Royal College. Rifa, can't see where Rifa is, lost her. Oh, right, on video, I beg your pardon. So I'm apologies, I wasn't aware. So Rifa's going to give us a talk on how we collate this information, because ePortfolio, it did seem a bit of a bad word with trainees, and some trainees still think of it as a bit of a hindrance to their training. It's integral to training. And if we can make ePortfolio work for trainees and trainers alike and populate the sort of information that we require to be able to assess and then trust a trainee, that's what we should be doing. So hopefully Rifa is able to tell us how that's all happening. So over to the video, thanks.
Hi, my name is Rifa Begum. I'm a CPD and ePortfolio manager. I will be just going through the ePortfolio developments that we'll be making to support the new curriculum. The changes we are making to the ePortfolio will be on the same ePortfolio you are already using and familiar with. The key changes that we'll be making will be introducing the new 2022 curricula for each specialty. We'll be creating a new education supervisors report for each specialty and creating the multiple consultant report for each specialty. We will also be developing a summary of progression page and also updating any existing or developing new special-specific assessment forms where applicable. The new curricula are SITS-based, and the SITS will be grouped in modules. They will be displayed on the curriculum page of the portfolio. So here an example of what one of the specialty curriculums will be displayed as. The curriculum is broken down into each module, and they are based around the generic capabilities, internal medicine capabilities, specialist capabilities, and practical procedures where applicable. We have introduced new ratings for the generic SIPs, and these are below, meets, and above. Ratings for internal medicine and specialist SIPs, we have introduced a new level 1 to 4 ratings. For those specialties that have practical procedures, we have introduced a new rating scale to sign off procedures. The Education Supervisor report that we'll be creating, it will be designed for each specialty, and it will incorporate the generic and specialist SIPs. There will also be a separate Education Supervisor report for internal medicine. The report will auto-populate the latest ratings and comments made by the Education Supervisor taken from the curriculum page. The education supervisor must ensure that they update the curriculum with the latest rating and comments for each SIP prior to creating the report. So, how will the auto-population work? The education supervisor will need to add a rating and comment on the trainee's progression on the curriculum page. The supervisor will then need to generate the ESR, which will then automatically pull the latest ratings and comments from the curriculum page. Here is an example of a rating that's been made by a supervisor under the generic capabilities SIP. The system will check the latest rating that was made, and this will be what is auto-populated into the ESR form. So here's an example. When the supervised report is created, the SIPs and the rating comments will auto-populate for the relevant SIPs. The form can be saved in draft if the ratings or comments need to be updated before completing the report. If the education supervisor form is saved in draft, it will update any changes to the curriculum ratings and comments until it's saved as a final version. So it is important to make sure before or during completing the ESR report that you make sure the ratings and comments for each SIP has been updated to reflect this on the supervised report. Within the supervised report, there is a summary of evidence for each specialty. The requirements for each specialty will be detailed in the ARCP decision aid, and this will be also reflected on the form. The multiple consultant report is designed for each specialty, and it will incorporate the generic internal medicine and special SIPs. The form is to be completed by consultants or associate specialists, specialty doctors who are able to provide feedback on a trainee's clinical performance. Once the MCRs have been completed, they will be collated and summarised in the MCR year summary sheet. There will be a minimum number of responses required before the summary can be created and viewed by the trainee. Here an example of an MCR form that we have created. The form has been split between the generic SIPs, internal medicine SIPs, and special SIPs. Clinical supervisors will need to record their rating for each SIP. They should only record feedback for the SIPs they have observed. Where they have not observed the trainee, there is a rating for not observed, and if that applies, they need to select this option. The new summary of progression page. So this page will provide an overview of key evidence recorded in the portfolio. It will be designed for each specialty, and it's organised in sections that reflect the specialty ARCP decision aid. The requirements will be based on the training year and will display the minimum that the trainee needs to achieve. It will auto-populate and display the latest data or the evidence within the portfolio. And it can be used for meetings between supervisors and trainees and for ARCP reviews. Here an example of the summary of progress page that we've built for haematology. The requirements have been taken from the haematology ARCP decision aid. Within each grade, there is a requirement, and each section will be auto-populated where there is evidence. So, under section 1, Education Supervisor Report, the system will look through the portfolio to see if an Education Supervisor Report has been completed for that grade. If it has, it will auto-populate and display here. Where there is no evidence recorded, it will display no information, as there's no evidence in the system. For the generic capabilities, the system will look at the overall total ratings that have been rated for the trainee, and it will just give a total number of ratings that have been rated for above, meets, and below. For the specialty SIPs, it will outline the minimum requirements for each grade of training, and there will be a minimum level to be achieved by the trainee. There is a column for evidence where it will auto-populate the evidence that's rated on the curriculum page. Where the minimum requirement matches the evidence that's been populated on the curriculum page, it will turn green to say the evidence matches the minimum level required. Where there is no evidence or the evidence doesn't meet the minimum requirement, it will just be greyed and there will be no colours populating. Similarly, with the practical procedures, the same rules apply. There is a minimum requirement for each grade, and if evidence matches the minimum requirement, it will just turn green. Where there's no evidence, there will be no colours populating or being displayed. So the key requirement to this particular form is if there is evidence that has been saved on the portfolio and it's been recorded, and it meets a specific indicative target required for that year of training, it will be auto-populated here, and where it's indicated, it will turn green to show that minimum requirement has been met. This form is very important when reviewing the trainee during an ARCP review or having one-to-ones with trainees to check on their progress and where they are and what is outstanding. To give you an idea of the expected implementation timeline, so for August, we will be going live with the new 2022 special curriculums. We will be going live with the multiple consultant report and any special specific forms that is required or updated, they will also be going live. Expected delivery. So we have two key forms that will be delivered in towards the end of 2022 and early 2023. So the Education Supervisor Report we hope to deliver in Q4 of this year and early next year. And the final development for the summary of progression page, we hope to get that delivered and go live in Q2 or Q3 of next year. So this has summarised the key developments that you should be expecting for August and in the next couple of months. Thank you very much.
Thanks, Riva. I think you can all agree that there's been a power of work done on ePortfolio. And for those of you who have been involved in IM Stage 1, the summary of progress document is invaluable. It makes the whole ARCP process seamless, and it's been an invaluable addition. So I'm hoping that that would be the case here. My only slight alarm is the thought of the summary of progress being live in Q3 of next year, since that comes after the ARCPs. So I think we really need that in Q2. That's imperative. Okay, can I ask today's speakers to maybe come out and join us at the front? And we're going to move to a Q&A session now. We also have Mike and Phil Bright on, and I think, yes, there we go. Remarkably big, that's remarkable, that's quite terrifying. But welcome, Phil. I've introduced Phil before. He's a clinical advisor for IMT for HEE, and he's the head of the West Midlands Postgraduate Medical School. And we've already heard from Mike. So can you hear me okay, Mike and Phil? Yeah? And can we hear you? Can we hear Mike? No, all silent. We'll just make sure that we can hear you. So the answer session might be interesting without any verbal answers coming. So I'm going to kick off with, first of all, in the audience. Does anyone have a question from the audience? We have a roving mic with Vicky roving round. So we have a question at the front. Vicky will bring the mic down. Could you introduce yourself as well? That'd be great.
Hi, good afternoon, everybody. Tom Gilpin, I'm the British Junior Cardiologists Association trainee rep and on the cardiology SAC, and I'm a trainee in Wessex. Thanks for today. I've got a couple of questions, a couple of generic and then some specialty specific. So the first one is, how is academic training going to fit in with the new curriculum? And is this going to dissuade trainees from undertaking clinical lectureship posts? And how are they going to do that? Plus subspecialty training, plus GIM.
That's a really important question. I see Mike flinching in the background, so I'm going to come to Mike, because I think Mike might be the best person to answer. Mike?
Can you hear me?
Yes, we can. Yeah.
Excellent. Okay. We're actively engaged with the academic community. Indeed, I've got a meeting tomorrow after the survey that we've sent out to academic trainees to try and work out how we get focus groups to investigate precisely what you're saying. So at the moment, that is work in progress. We would certainly hope that any changes to curricula do not discourage people from entering academic training. It's the last thing we want to do. So we're trying to work out how we best promote academic training at the same time as recognizing that the indivisibility between internal medicine and the Group 1 specialties will remain. And so there is a lot of work to be done to try and ensure that we are providing good academic pathways.
Okay, yeah, so a sort of follow-up question to that, which is kind of linked, and again, I'm hoping this is generic to every specialty, is how is the JRC PTB going to monitor the impact that the new curriculum has on specialty training over the next years, i.e. we can't wait until 5 years' time to realise that people are coming out at the end not of good quality in their specialty?
I'll maybe come to Phil on that, if that's possible. Phil?
Okay, the quantitative bit is the easy bit to do, in a way, and all of the statutory education bodies monitor very, very carefully the ARCP outcomes and the time pathway of individual trainees, groups of trainees, and trainees as a whole as they progress through training. The monitoring of the quality is partly a function, largely a function of the ARCPs themselves, but actually monitoring how confident trainees feel, how prepared trainees are to do the job, that's a much more difficult challenge, but for which we have a number of surveys, both the SBE surveys, the GMC surveys, and of course the JRC PTB survey, which is adapted and changed as the year goes by, or years go by.
I think Mike wants to come in.
Yeah, the other aspect, whilst Phil has mentioned the GMC survey, we've managed to have extremely productive talks with the GMC, looking at specialty questions, which we've worked with the SACs. Although there is a reduced number of questions, we are trying to get this incorporated right across internal medicine and the specialties so that we get good qualitative data about how training is proceeding right across the 4 nations.
Excellent.
Yeah,
one
sorry.
final question.
So currently 85% of cardiology trainees in the UK say that they need at least 1 to 2 years post-CCT to be able to secure a substantive consultant post in their chosen subspecialty. Is this not going to get worse with the new curriculum, i.e. people are going to have to do more in the same amount of time? And if you need 2 years post-CCT to get a consultant job, is the training programme fit for purpose? I'm going to ask Colin here. Given that Colin has a dual hat on as a cardiologist,
So the purpose of any curriculum and any CCT is to say that someone is at a particular standard, which allows them to do a specific series of tasks and series of roles and perform a series of functions within general medicine, cardiology, or whatever. We are not necessarily in the business of training every cardiologist to be an electrophysiologist or to be a PCI doctor, and therefore it may well be just as in gastroenterology. If you want to develop higher skills in hepatology, you may be required to go and do additional training. So there is a fundamental difference, and we do need to be clear of this. There's a fundamental difference between training someone and the job you end up doing. Now,
Sorry, Colin. Can I just interrupt? I can't hear you. I don't think Phil can hear you. And if it's being recorded, we probably need a mic for you. So could you get a roving mic?
Sure.
I know this mic isn't roving, but could you get one down
Sorry
there?
about that. Can you hear?
Still not. Yeah, I can hear you, David, but I can't hear Colin.
Hello, is this mic on?
No, still not working.
Take two.
Excellent.
Thank you. Basically, I was just saying that the purpose of a curriculum is to train individuals to do a certain level of work, and that the job that they are subsequently required to do, which is a point of employment, is a completely different requirement. So the fact that you are trained to a certain level that allows you to do a generic job is the purpose of the training specialty. It may well be that there are other employment requirements that you're needed to do a specific role when you're appointed as a consultant. So I can understand the question as to whether or not the training curriculum is fit for purpose, but I think there are two completely different questions. One is what we're trained to do, which is the generic role of rheumatologists, physicians, chest physicians, etc., 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 and those specific requirements that we are required to do as part and parcel of our day-to-day job once we become a consultant, which is a contractual issue, for which, yes, we do require training, but it doesn't necessarily need to come under the generic training that all who enter that discipline require to be trained to.
I think Sue wants to come in also.
Thanks, David. I'd just like to add to that, I guess, and perhaps be a little bit controversial. I was delighted to hear that you are a geriatrician specialising in patients with complex multimorbidity and perhaps in your case mainly cardiological problems. I, as a geriatrician, cannot look after every patient with frailty and multimorbidity. This is only going to work, this new push towards developing generalist skills and us all becoming good physicians in whichever specialty we specialise, if the jobs we then go on to do as consultants continue to use those generalist skills. There's no point us training you all in these fantastic generalist, good physicianly skills if the minute you CCT, you then stop using them. So I think that is a challenge for our trusts, for our health boards, as to what types of consultant posts we advertise, and continuing to ensure that our patients benefit from us all knowing how to manage multimorbidity.
I think that's a hugely relevant point. It comes back to the point I said from John Paul Leach saying, who is a better neurologist for not being trained as a physician? And I do think that the pendulum, personally, I feel the pendulum had swung towards specialisation, and cardiology is an absolute example of where it was subspecialisation that the pendulum swung to. And what we're trying to do is swing the pendulum back to say, actually, as a cardiologist, I am managing people with multi-organ disease, and I'm not just interested in the right or the left coronary arteries. Being conscientious, or controversial, sorry. I'm going to take some questions before I come to the back. If you don't mind, I've got questions online as well, so we'll come to you in a second. So I've got a question from a lead dean for less than full time, which says that the curriculum is capability-based and not time-based. Yet it is suggested that there are minimum blocks of time in some of the aspects of training, and this is causing difficulties in managing programmes, especially if there is a short pro rata extension. So perhaps I might actually come to Phil with that in terms of both your deanery and head of school role. How do we deal with the less than full-time question, given the way we're moving forward?
So it does all come back to the demonstration of capability over time served. If somebody is asking for their capability to be considered, but having done less time than the indicative time, that is going to require much more and deeper evidence for that to be accepted. So there's a balance between the two there. If someone can demonstrate the duration of their training, be that full-time or less than full-time, is at or above the indicative level, then you're not going to, I suspect, look as deeply and require as much evidence to prove that capability has been achieved as you would if someone does it in significantly shorter time than the indicative time. It is a balance. We are noticing that a number of less than full-time trainees are now saying to us, we have met our capabilities and we think we should therefore do it not in the pro rata time, but actually in the absolute calendar time of our full-time colleagues. That's difficult and it's challenging to the system, and we do need to work that through and come to a point of understanding as to just how we approach and accept that situation.
I think that's a really difficult one, because you can imagine the ire and irritability of those trainees who are full-time if they see less than full-time trainees obtaining CCT and they're having to spend a longer period, whether they're in 80% or 60% compared to the 100% trainees. So it is capability based, but inevitably that will result in some of those full-time trainees accelerating their CCT. So I'd maybe I'll come to Raghu and then Mike on the question of acceleration, because Becky, who had to leave over coffee, was asking the very questions about what do we do about acceleration. So Raghu and then Mike. Can we wait for the mic, Raghu?
Sorry.
Yeah, I think we need the full mic.
Okay. Can you hear me? Phil has explained this beautifully. I think where there is a capability-based curriculum, we really can't differentiate between the length of training in its truest sense. However, many of the capabilities in practice will require a certain amount of experience to be demonstrated. And I hear what Phil's saying about the rigor. I think the RP panels will give due diligence to every trainee. And if the trainees are progressing, whether they're full-time or less than full-time, they are progressing ahead, then that's recognized at the RP. And we need to do that cumulatively and progressively as we go along. The important bit for me is a recognition that we do have an increasing number of trainees who are going to work less than full-time. We have to learn to adapt and adopt to this and find a way through to support all our trainees, because it's tough out there. And what we don't want to do is to lower the standards, but we want to be supportive to our trainees. And I think we would trust the judgment of the RP panels and with the support of their postgraduate deans and the heads of school. And that's the way I would leave it. I don't think we can have a one-size-fits-all in this case. Happy to be a minority of one on this.
I think I would add to that there's also a document on the JRC PTB website regarding acceleration of training.
Yes.
And we've discussed this at considerable length at the Curriculum Development Group. And whilst it's not a time-based curriculum, it's competency-based, you do need time to gain those competencies. So you cannot expect a trainee to be level 4 competent on all generic and specialty SIPs in 2 years. They may be able to do it in 3 years if they're exceptional, but generally speaking, it takes time to gain those competencies. So whilst we've not embedded time into the curriculum guidance, there is an expectation that you cannot gain competence without actually doing the job. I'll go Mike and then Phil, because I'd asked Mike to make comment about the acceleration, if that's okay.
Yeah, that's fine. Acceleration, as you say, there is a paper on the PTB website, but I think we also need to bear in mind that the curricula for all the Group 1 specialties have been written by those who have been in training as trainers for a significant period of time and recognise how quickly, on average, people are adapting and acquiring the capabilities and the competences. Therefore, almost by definition, those who are accelerating are going to be those who are showing very, very significant progress at a much faster rate. because what we're anticipating is that the vast majority of people will be progressing at the mean, because that is the way that we have geared things. So the ARCP process is critical. It is at that point in time a decision will be made. We have to make sure that the MCRs and the ESR are adequately informed, especially if a trainee believes that they should be accelerating, because it is at that point in time, the ARCP, that recommendation needs to be made and assessed by the ARCP panel. And a very strong case would have to be made simply on the basis that we are looking at those who are exceptional should be allowed to progress, because, as I think we're all saying, there is a degree of experiential learning to be able to adapt capabilities.
I think the other thing to add to that, Mike, is the acknowledgement that we occasionally see specialties saying that a trainee is exceptional in specialty, but the CCT date for both medicine and specialty have to coincide. So you cannot accelerate in specialty and expect to get a CCT unless you're hitting the same targets with your internal medicine. So they both have to coincide.
Absolutely agree.
Phil, do you want to come in?
Thank you. A lot also comes down to what is behind the asking of the question. Yes, it is possible to accelerate through the training program and to meet the minimum standards, but in many ways that is demonstrating adequacy rather than becoming the best you can be within the supported training environment. So yes, there is a financial need to get through training because the salary goes up, but actually that's quite short-term, a short-term approach to it. One would hope that people are more focused on, let me make the most out of the training environment to become the best I possibly can while utilising the resources of the training environment.
Thank you both. We'll go to our question at the back, if that's okay.
Thank you. I'm Ellen Dwyer. I'm the TPD for GU Medicine in North West London, and it was really in response to Dr. Pound's point, which I think was really interesting and really important. The idea of this training is that we're hopefully developing more holistic doctors with more generic skills, and I think that is really important in HIV medicine. A lot of the patients I look after are getting older, they're developing more comorbidities, and I often diagnose hypertension, diabetes, hypercholesterolemia. The issue is the commissioning of services, so I am not allowed currently to provide treatment in these specific areas. Do you think commissioning structures will change? Are they going to have to change to help us? I mean, what's the point in developing these generic clinicians who won't then be able to prescribe appropriately for these patients? Just be interested in everyone's thoughts on that.
I just caught GU medicine.
Yeah, I'm GU medicine.
So, of course, you've touched on a really important point about GU medicine, particularly south of Carlisle, being largely outsourced to private centres, and therefore So certainly, I know that the
complex. But HIV services are commissioned by NHS England.
Okay.
So HIV services are commissioned by NHS England, GU services are commissioned by local authorities, and some elements by CCGs. So it is really complex, and I just wonder, are the future roles going to change to,
personally, I think the answer will be undoubtedly yes. Mike?
Yeah, again, recognise that the commissioning model, especially south of the border, is extremely difficult and makes life very, very difficult, A, for those functioning within that commissioning envelope, but also we have seen a continued decrease in recruitment into GUM, and a large component of that, we believe, including those leading the specialty, is because of the commissioning model. And I think we do need to look at this. We've had discussions about it, and we're trying to do something about it. It's not specifically curricular, but I agree entirely that if you're recognising that somebody has comorbidities, we should have the ability to treat those, even if their primary problem is related to their HIV or their GU condition. So I completely support that. We are trying to influence that, but again, that's going to take influence centrally.
So in terms of prescribing, Mike, so for a GU physician who will be dual trained, the question, I think if I'm correct, is will I be able to start prescribing for hypertension or for hyperlipidemia or whatever? Surely the answer has to be yes.
You would certainly hope so, but because of the commissioning model, there are difficulties associated with that, as the doctor that's speaking has alluded to. Yeah. We need to make sure we break down those barriers.
Liz at the back, Liz Murphy.
Thanks very much. I'm Liz Murphy and I'm Director of Medical Education and Training in the Glasgow College, but I also have a role as an Associate Dean for Careers and for Performance Support. And my question really is, while I absolutely understand and support the direction of travel to have more generalists, I think an unavoidable consequence will be there are some trainees who I will have to say in a career discussion, you are not going to be able to complete physicianly training because you have a disability or you have a neurodiverse condition or you have whatever, lots of reasons, which means that they could previously have trained in a specialty but not completed the general medicine bit of it, and that will no longer be open to them. So my question really is, do we as a group of physicians accept that this is perhaps going to make us a less diverse group of doctors moving forward, and is that a price worth paying for all the benefits that we have heard about today, making us more generalist in our approach?
I think, again, a really important question, Liz, and it has been discussed, as you know, at GRC, PTB and at curriculum development level. And there is no division of the two curricula. You will not be able to single a credit in general internal medicine easily, but there are the possibilities of doing that. What you cannot do is the opposite of being a specialist without GIM. And that will cause problems to the very cohort of trainees that you discussed. And I don't think we've had really the depth of thought into what happens and the career guidance that's required for those trainees. They will not be completing a CCT in specialty only because that is not a physical option as we currently stand. Maybe Mike, anything you wanted to add to what I've said there?
Yeah, no, I think that your point is well made. It has been highlighted, the GMC, and the GMC felt that the progression as has been outlined, i.e. that internal medicine and specialty would not be subdivisible, was an acceptable approach from the GMC point of view. So given that the regulator supported this, whilst I absolutely understand the point Liz is making, we have tried to make sure that all the developments that we are making are pertinent as regards what the GMC believes. But the other aspect to it is, of course, the cross-recognition of capabilities between curricula and, for instance, some of the Group 2 specialties that is likely to make that sort of transfer easier, but we need to look at each individual case as it crops up.
Thanks, Mike. We're going to come. Oh, we've got a mic coming over to this side. We have two questions on this side, and then I'm going to take some questions from my trusty iPad here.
Hi, hello there. My name is Tony Hickin. I'm a lay member on the respiratory SAC. I'll need to beg your forbearance with if I get any of the medical stuff wrong. I'm not a medical professional. My background is actually in project and program management. I spent 30 odd years doing stuff in things as diverse as banking and the Metropolitan Police and forensics. I'm totally sold on everything you're trying to do, and I know from what I've seen on the respiratory SAC, the commitment to making this work. With my project hat on, the one thing I've been a little bit surprised on, even from some of the questions today and from what we've heard today, what's going to happen in terms of support going forward? Because over the years, I've seen some fantastic initiatives actually fail through poor implementation and the whole post-implementation process, picking up lessons learned. Things like the educational supervisors and the clinical supervisors seem to be key. As I say, to a layperson, it sounds like there isn't necessarily any consistent training that's going to happen there, or some like standard operating procedures. So I just wondered if you could give me any reassurances on that.
You must have read the iPad, because my next point and question was exactly that. It was, if I can maybe paraphrase the question here, it was regarding how much time educational supervisors will be given to provide the support for the trainees, because clearly this is much more of a holistic approach to assessment, and it requires good, exceptionally good, high quality educational supervision. And perhaps in the past there have been areas that have paid lip service to educational supervision. So how do we improve that, I think, is the question. I'd maybe come to Sue and then to Raghu. Or will I do Raghu and then Sue? Let's do Raghu and then Sue. Raghu had his hand up.
Oh, Megan and I do a double act.
No, I think that's a really important question. I think there are two things here for me. I think each SAC needs to work with their own TPDs, and then educational supervisors and clinical supervisors, so almost disseminating it down the tree, if you like. Speaking from my specialty in my deanery, Scotland, we have plans for sort of continuous updates of our educational supervisors and TPDs, and then encouraging them to filter down to the clinical supervisors. And I think, from what I'm aware, most other SACs have a similar plan in place. I think the more difficult question is what David's just alluded to, actually, is ensuring that educational supervisors in the workplace, whilst they may have set aside times in their job plan to do educational supervision, is actually ensuring that time happens. So, and trainees too, to be fair, actually ensuring that there is that time to meet weekly with your educational supervisor if required, and certainly your clinical supervisor. And I think that will be more challenging to deliver, and I'm not sure that I have a clear answer to that.
Megan.
I think that's a really important point, and I think it also links in with a couple of things that have been said about perhaps reducing the diversity in the workforce, and about how we monitor the clinical competence, essentially, of people coming out at the end and CCTing, and whether they are fit for consultant posts. A lot of this is going to be about collecting data. We need to see whether the shape of our workforce is changing. We need to be able to get people's opinions about the implementation, both from a supervision and a trainee perspective. And of course, we need to have the data to compare it to. So we need to see what all of that looked like on the old curriculum. We need to do the equivalent of sort of exit interviews or surveys of the people who have already CCT'd or who are CCTing in the past 12 months, for instance. So we have some comparative data so we can see how things are changing. And I think it's really important that we do keep monitoring it, and so we can act, as you say, use that implementation science, act on things as they come up, change things as we need to, create the training for supervisors, for instance, if they don't feel empowered and sufficiently knowledgeable about the curriculum. All of this needs to be a continuing process over the next couple of years as the curricula bed in and we all become more familiar with them.
Thank you. Just to reassure you, sir, when we introduced IM Stage 1, these were exactly the kind of questions we were asking. And I have to say, we went through this whole process of supporting and both our trainees and our trainers. And I have to say that now that the first of the IM3s have come through, I'm relieved, delighted, proud that the vast, vast majority of our trainees and trainers have come through this. And they will be the cohort that's going through the system now and understanding the new ways of working. So yes, we will have lessons learned from the past 3 years to look at and try and adapt and adopt. But the key is what Megan said. It is continuous monitoring of it. Yes, there's survey fatigue. Yes, there's a lot to do. But unless we learn early, the RP is too late. And that's why I'm absolutely clear that the continuous conversations between the local education providers and the entities formerly known as deaneries is important so that we can get that conversation and support them. If we don't do it, then a whole year's gone before we could intervene. And that I want to empower the trainees and the trainers to tell us if there are issues early, and we will intervene.
I think the other imperative thing to maybe reassure you is that the education programme driven by the college for educational supervisors is there, so that we need to make sure that educational supervisors realise the differences between old assessment and new assessment. And that's a rolling process which is going out. We did it very much with IM Stage 1. We're about to go down that route with IM Stage 2. So I think it will be there. Colin?
Yeah, just to give a shout out to Ian Forrest and the respiratory team in the north. They and their education supervisors are miles ahead of this, and of all of the existing Group 1 specialties, not the new Group 1 specialties who have put together a completely different programme, but of the existing Group 1 specialties, respiratory medicine, certainly in my region, are miles ahead of this than everyone else. Probably because you're asking them those sort of questions at SAC, so thank you.
And not a plant in the audience, I hasten to add. Not like question time, no. Can we have the microphone over this side, please? We'll have this final question from the audience, and then I'm just going to make one question from the iPad.
Hi, I'm Fitz. I was the trainee rep on the Gastro SAC and the ex-chair of the RCP Trainees Committee. Going forward from the curricula, if we look at specialty training versus internal medicine training at the GMC National Trainee Survey or the RCP census, people rate their specialty training as high quality, they really enjoy it, and they're very satisfied with it. And they rate their IM training consistently less well, more of a balance of service provision and less enjoyable. How do we make internal medicine training great again? How do we put some joy back into it so people enjoy and are satisfied with their training to the same degree as they are their other specialty?
I'm maybe going to say a few words on that. I think we need to change people's perception of what it is to be a trainee. And I think that it's this pendulum that I mentioned. I think that people go into specialty training thinking I'm a gastroenterologist first, and the medicine's a bit of a nuisance that gets in the way of my gastroenterology training. I think we need to break that. I think we absolutely have to get away from that concept, and that your future working life, it's unlikely that you will be working as a purely gastroenterology without any internal medicine impact. And certainly within your gastroenterology practice, you'll have multi-faceted illness across the panoply of the patients that you look after. So what we need is to change the mindset. And the problem is that the mindset has been there since the pendulum swung towards specialty. And it's a hearts and minds game to move it back, where people are thinking, the medicine's not getting in the way of my specialty training, the medicine is making me a better doctor. That's my personal feeling. Mike had his hand up. Or did you, Mike? No?
Yeah, no, I absolutely, I'm more than happy to comment on that, because the other aspect to this and what I'm coming across as I travel around the country is that we need to make sure that the present consultant cadre is also promoting the interest and enthusiasm for general medicine, because without that, role models are very, very strong. And I think it's fair to say that as we get more buy-in, then we will see that internal medicine is improving. There is no doubt from the feedback we're getting as regards IMT stage 1 that people are feeling much better prepared for the medical registrar role, for instance. But that is patchy. We're needing to make sure that people are properly being trained within internal medicine and not just left to fight fires and left on their own trying to manage the tsunami of patients coming through the front door. And I think that is part of the education we need within the NHS itself, so that people are recognizing that what we're doing is fairly critical from the physician's point of view. 92% of patients in all of the medical wards have come through the acute pathway. And yet I'm still trying to, under another hat, I'm still trying to persuade organisations that perhaps their specialties need to play in to the internal medicine part of care. So we've got to get a different ethos really well inculcated so that people recognise what's coming through the front door is specialty and internal medicine, and then perhaps we will have more trainees who are enthusiastic about managing the acute problems.
It kind of leads to the question that I was going to finish with, and it's a question about team work and dissatisfaction, and it was a point raised. One of the major issues underlying trainee dissatisfaction is a loss of team structure. Are there ways that this can be overcome to improve trainee and trainer feedback? Phil, there's a tough one.
Then one of the first things to consider is that we need to stop equating acute unselected take with GIM. The two are different. We then need to start to get departments to become the village that owns the trainees and work together. Now, this is not wholly within the gift of us as trainers. It is more in the gift of providers. And by coincidence, the trainers and the providers, at least in England, are going to be under the same organisation banner. It is about bringing together trust aspirations to redevelop departments of general internal medicine. In the United States, the hospitalist is now the fastest growing physician specialty. And you have to ask yourself why that is. And it's because they have a good team structure that underpins it. To a large extent, we are inhibited in our ambitions in that direction by contractual constraints, but they are not insurmountable. And with good locally developed working practices, I think we can bring back, to a large extent, the feeling of ownership, not within maybe the small consultant team unit, but within a larger departmental site team unit that gives back some of the benefits that we saw in medical practice 20 or 30 years ago.
I'll maybe highlight what Phil said with an example from Scotland. And one of our specialties, which I shall not name, has a tertiary referral centre. And their trainees are dual accrediting. They're Group 1 specialty. But the trainees currently do very minimal general medicine, in fact, no general medicine when they're working in the tertiary centre. And they spend, at the moment, 4 out of 5 years in the tertiary centre. And it's got to the stage where those trainees in the tertiary centre, if a patient goes into AF, they phone the cardiologist. That's what we've got to change. And I think this mindset of I am an ologist rather than I'm a doctor is where we've gone wrong. But again, that's my personal feeling. So I have an axe to grind on it. I'm more than happy to say that. Anyway, one final comment, and it's a comment that's come across to Dr. Doig. Okay, and it's 2 people online have said, look like scroll down and find it. Dr. Doig thinks that ambulatory care is a glorified DVT clinic. And another has said that our ambulatory care clinics are wonderful and provide fantastic service. I think you alluded to this, but I'm landing with a slight finish of humour here.
Yeah, and I think it's wonderful how comments can be taken entirely out of context and misrepresented, which is one reason why I never go on social media. The question about ambulatory care being glorified DVT clinics, I'm delighted that whoever has made the comment is kind of implying that where he or she works, that is not the situation. If that were the case all around the country, then we wouldn't have needed to make the comment that we did make. And secondly, I'm delighted that there are other examples of ambulatory care clinics where they feel the experience is excellent. And again, within the north of England, there are plenty of examples where the ambulatory care clinics are fantastic learning experiences and where general medicine in all of its colours are demonstrated. That is not true throughout the country and across the 4 nations.
Yes, I would absolutely concur with that. Okay, folks, we've overrun the time. My apologies as chairman today for that error. I think we can safely say it's been, I think, a very successful launch today. I'm greatly indebted to the panel for their expert talks, also to Mike and Phil for fielding some answers, and obviously to Professor Sir Chris Whitty for his excellent opening to the session today. I think if we finish with a thought, when we started this 6 years ago, we kind of didn't think we'd get to the point that we're at, and we've got to this point through a lot of hard work, but a lot of dedication from a lot of people that we've heard of today. But we've also brought, I think, the trainees with us. And the negative comments that we hear about training, we need to take on board. We cannot brush things under the carpet because it's not perfect. But the number of positive comments that we've seen have been wonderful. And I think that IM Stage 1, the feedback that we have across the UK, and the evidence in terms of people applying for jobs in IM Stage 1 is proof of the pudding. I think we got IM Stage 1 right. We shouldn't rest on our laurels. I think we now need to make IM Stage 2 right. And with that, I'd like to thank everyone for their contribution, and we exit to the garden for a little refreshment. So thank you very much.